Hello, everyone. I'm Dr. Zia. I'm the Registrar of Renal Medicine in Tarrant Valley Hospital, and I thank Medics United for giving me the opportunity to speak to you. Today, we'll be talking about a practical approach to acute kidney injury, the cases that can come on acute medical take. Um, so, just to give you a brief perspective of why it's important that we are talking about it is that 1 in 5 emergency admissions to hospitals all over the world and in UK or because of AKI, and the mortality is very high. It's around 33%, and when it comes to ITU patients in ITU with AKI, the mortality goes way above 50%. So it's something that has quite significant morbidity and mortality. So we need to know about it and we need to prevent it. So what we are going to speak in this talk will be there are a few cases of acute kidney injury that can come at any acute medical take. So we are going to talk about that, and then briefly touch the subject of contrast-induced AKI. Then we are going to speak about the COVID and its effects on the kidneys. And I'll just touch the subject of renal replacement therapy. I know it's a very vast subject, but I'll just give you the briefs of what we can do with the patient. So let's talk about the first case. So it's an 82-year-old male patient admitted with fractured neck of femur. He's on NSAIDs for that. He developed dyspnea while he was in the hospital. So naturally, a CTPA pulmonary angiogram was done, but it only revealed a pneumonia and ruled out any pulmonary embolism. His past medical history is quite significant for a chronic kidney disease, ischemic heart disease, hypertension, diabetes, and he's on EC inhibitors. His baseline renal functions are a creatinine of 140, and his creatinine on admission is 250. While on day 7, his creatinine jumped to 560 with metabolic decompensation in the form of potassium of 6.5 and metabolic acidosis with bicarb of 13. Just for my Pakistani colleagues, the creatinine values here, they are in micromoles. I know in North America and Pakistan, the values are given in milligram. The conversion factor, to be exact, is 88, so divided it by 88. But for all practical reasons, I personally divided by 100 because, a few number here and there won't make any difference in management. So just divided by 100. So creatinine of 140 divided by 100 means creatinine of 1.4 in milligrams, and vice versa. So it's just because I know a lot of my colleagues in Pakistan they are giving exams like MRCP, plus also some of the labs in Pakistan, they give units in micromoles. And if you're not used to it, then it can create a bit of confusion. So it's just for simplicity, divided by 100 or multiplied by 100 if it's there in milligram. So let's say you get a creatinine of 3, multiplied by 100, it's 300 micromoles. Or if here in this situation, the creatinine is 250, divided by 100, the creatinine is 2.5 milligram in milligrams. All right, so as this patient had metabolic decompensation with AKI3, so he was started on hemodialysis and further management. His creatinine on discharge was 200, and the patient got stabilized over time and he was discharged. So in a situation like this, when you get a patient like this, So how will we approach this patient? What should be our approach? Um, so just for the sake of simplicity, I think if I'm a resident on call in any medical take, I'll just ask myself few questions of what I'll do. So the important thing is that I'll ask is the first thing is that what are the risk factors and what are the causes for this deranged renal functions. If we come to this case, so uh, he's 82-year-old. He's above 65, which is one of the most important risk factor for AKI. He had a chronic kidney disease. He had an ischemic heart disease, his hypertension, diabetes, and he's already on ACE inhibitors. So these are some of the very important risk factors to develop acute kidney injury. On top of that, to make things worse, he had a fractured neck of femur. There will be some blood loss. He's using NSAIDs, which we know that they are nephrotoxic, and he had some contrast as well, which again is nephrotoxic, and he already also had an ammonia, which is an infection. So he had a compounding risk factors with acute on top of chronic risk factors. The other thing the question that I would ask myself would be whether this patient is stable enough to buy me some time, or I need to do something in emergency. So whether there is anything, whether he's hemodynamically stable or not. So go through the ABCDE approach. That is the airway, breathing, circulation, and deformity and exposure. So go through that simple basic steps. Make sure that the patient is hemodynamically stable, make sure the patient is breathing, his normal circulation, and everything. And then there are some acute complications of AKI, which would demand emergency measures to be taken. We are going to discuss about that in a while. So make sure that the patient is stable. And I'll ask myself that I'm not dealing with an emergency. And then the other question that I would like to ask myself would be whether I'm dealing with an acute kidney injury or whether this is something chronic. So um, that's also important, and because that will change your management and how to deal with the patient. So we can see previous clinical letters. We can check any previous renal function that were done, any ultrasound report in the past. So things like that can give us a clue whether this patient we are dealing with an acute kidney injury, or it's a chronic kidney injury, or whether it's acute on top of a chronic kidney disease. And then obviously we need to do some investigations and treat the patient. Um, in this case, we know that the risk factors are there. Um, and then for the cause, we normally divide for simplicity and just to not miss anything, to be thorough, we divide it into pre-renal, renal, and post-renal. In this case, we have, I think, we are dealing with a pre-renal sort of a situation, and on top of that, we also have a renal injury as well. So it's a complex compound injury, kidney injury that we are dealing with. Okay, just to go through some of the causes. As I said, we divide into a pre-renal. So pre-renal injuries include hypovolemia, cardiac failure, hepatorenal syndromes. They all come in the context of pre-renal injuries. And then we have renal artery occlusions or large or medium vessel vasculitides. They can also come in the pre-renal form of injury. And then we have the renal form of kidney injuries, which can range from small vessel vasculitides like thrombotic microangiopathies, small vessel vasculitides, glomerulonephritides like lupus nephritis, or all of your membranoproliferative GNs or IgA nephropathy. They all come in the renal form of kidney injuries. And then obviously we have the acute tubular necrosis, which can be caused by toxins, rhabdomyolysis, contrast agents, ischemia, so they can all lead to acute tubular necrosis. And then we have the interstitial injuries in the form of drugs, infections, systemic diseases, and intralobular obstructions like crystal nephropathy, cast nephropathy. And then obviously we come to post-renal obstruction in the form of tumors, calculi, and in rare cases, retroperitoneal fibrosis. One thing, just for learning purpose, the kidney in itself can be, the nephron in itself can be divided into 3, 4 different portions. So the glomeruli is a different portion of a kidney. Its diseases are different. The tubules are a different entity and its diseases are different. The interstitium is different. Its diseases are different. So make sure that you understand what you are dealing, whether it's a glomerular injury, whether it's a tubular injury, or whether it's an interstitial injury, because that can affect the management, although it's something related to something that the renal physician will deal with. All right. So, and then, as I said, the first thing that you look for is the risk factors. So, we know that if the patient had a chronic kidney disease, a chronic liver disease, or a heart failure, obviously he's at risk of developing an acute kidney injury. Diabetes and hypertension, we know that they are the leading causes for kidney injuries and chronic kidney disease. And then obviously we have the autoimmune and the cancers, and then the hypovolemia, sepsis, dehydration because of diarrhea, diuretics. um, Previous history of AKI is important, and why I'm saying this is that any episode of an acute kidney injury, and that's why prevention of AKI is important, and that's why detection of AKI is very important, because any injury, any kidney injury, will lead to loss of nephrons, and gradually over the time, if you get repeated acute kidney injuries, your loss of nephron is increasing, and so is your kidney functions are decreasing over the time, and the patient is at more of a risk of developing a new acute kidney injury. Obviously, drug history is very important, and you must ask about over-the-counter medication as well. Particularly in Pakistan, we know that homeopathy and all other quacks and everything. So they can give anything and everything to the patient. I'm not against any, herbal or homeopathy or anything, but just to make sure that you know what your patient is getting, that's important to me, because that can affect the kidneys. So deteriorating news score. So just for my Pakistani colleagues, news score is a national early warning sign. It's a scoring system based on 7 important observation like blood pressure, heart rate, temperature. So it develops into a score that the higher the score is, the more, deteriorated the patient is. So any deteriorating patient in a medical ward is at risk of developing acute kidney injury. Just to give you a perspective of the important causes of AKI in the hospital settings. So in this pie chart, we can see that almost 50% of the cases are because of acute tubular necrosis, which could be because of drugs, toxins, infections. They can all lead to acute tubular necrosis. We have a fair share of pre-renal acute kidney injuries, and also the post-renal acute kidney injuries. And also a major chunk is that of acute and chronic kidney diseases. Some other rare causes that we need to have in our minds, because they can come, are like pulmonary renal syndromes, hepatorenal syndrome, cardiorenal syndrome, and AKI in cancer patients. Remember that almost 50% of the cancer patients, particularly in terminal stages, they do develop acute kidney injuries, which is a major chunk. The causes can be multifactorial. It could be because of the chemotherapeutic drugs, in itself. It could be because of a dehydration, because of not drinking and vomiting. It could be because of infection, because they're immune suppressed. It could be because of the cancer in itself. So it's multifactorial. So always keep in your mind open. If you're dealing with any cancer patient, they are at risk to develop acute kidney injuries. In terms of management, I think the most, I mean, we've been listening that and hearing that history is the most important thing. Well, it is, because it will give you a fair clue of what you are dealing with. In history, you are looking for any risk factors that we already discussed. So drug history is important, previous comorbidity is important, any history of autoimmune disorders, family history, they're all very important, and it will give you a diagnosis. And then physical examination. Obviously, we are looking into signs and symptoms of chronic medical issues like diabetes, hypertension, CLDs, etc. But I think the point that I'll stress in physical examination is volume status. I think for any medical colleague or medical resident or medical physician, assessing accurate assessment of volume status is something which is very important. It can be done by just looking a thorough clinical examination, like a drop in postural, the drop in blood pressure and postural hypertension, tachycardia, sunken eyes, dry skin, or pedal edema, sacral edema, ascites. They can all give you a clue of what you're dealing with. You can also do some sophisticated and invasive procedures like CVP measurements and echo, and one of the tool, which is the point of care ultrasound that you can do and assess the inferior vena cava size. I think that's being used, and I think that is something that is very useful, non-invasive, to assess the volume status of patient. And urine output, I cannot stress enough on the importance of urine output. I know that when we used to ask our medical colleagues to accurately, intake output record and that, so I mean, they would think that why every renal doctor is after intake output record, and every patient, every call that we used to attend, we would write intake output record. Um, but I mean, that's the thing. The kidneys produce urine. So I mean, if I'm not asking about how much of a urine my kidney is producing, that what will I do? So that's my job, and it's my bread and butter to know about how much urine my kidney are producing. So urine output is very important, because if the patient is oliguric or anuric, that would totally change the management of the patient. And then obviously to know, as we said, AKI versus CKD. So obviously, if we have a previous clinical record, that's well and good, but sometimes the patient just pop in, and we don't know, they don't have any previous records with them. So then how to know about whether we are dealing with an AKI or CKD? Some tests can help you, like PTH, parathyroid hormone. If it's high, usually it's CKD. And then you can do an ultrasound to know about the kidney size and its echogenicity. There's a small picture of an ultrasound picture. Here, this is the liver, and along with it, this is a small shrunken kidney. And you can see that it's hyperechoic, and the cortex, this thin layer, it's very thinned out. Normally, it should be more than 10 millimeters, but here I think it's around about 3 millimeter, 4 millimeters. So just by looking at this picture, um, I think I can safely say that this patient had a chronic kidney disease. So imaging will help you of what you are dealing with. And then anemia, we know that CKD can give you anemia of chronic disease and erythropoietin deficiency anemia. Previous history and broad waxes cast on a urine microscopy. Obviously, you're going to do some tests. So the routine tests like um, creatinine, urea, phosphate, PTH. You're going to do all these. You're going to do, you take a VBG or an ABG, urine dip and microscopy. I think it's termed and dubbed as poor man's renal biopsy. And I think it does the justice to its name if it's done properly. Urine microscopy and dip can give you a lot of information if it's done properly, and you know what you're dealing with if you do a proper urine dip and microscopy. Just to rule out an infection, you would like to do a urine culture, and you would like to do some imaging in the form of CT KOB or an ultrasound KOB, or any further imaging that you would want. Fractional excretion of sodium, it's there in textbooks, and you can do it. So I'll just give you why we do it and what's the mindset and mechanism behind that. So we know that in a pre-renal situation, there's a problem with renal perfusion, and the GFR in itself is low because of decreased blood supply to the kidneys. The kidneys in itself, they are normal. So if they receive reduced amount of blood supply, so they'll hold on to whatever they get. They'll hold on to whatever sodium they are getting in the filtrate. So there will be very less sodium to be excreted, and the fractional excretion of sodium would be less than 1%. While in the case of ATN, acute tubular necrosis, where the problem is within the kidneys and within the kidney tubules, and we know that kidney tubules are absorbing almost everything. So if there's a problem with the absorbing mechanism, and the problem with the kidney itself, the kidney won't be able to hold on to whatever filtration is there. So the excretion of sodium will be high, and the fractional excretion of sodium would usually be more than 1%. So it's just this mechanism, the mindset behind why we do fractional excretion of sodium, why it's there in the textbooks. Blood test, if you suspect that there is hematuria and proteinuria on the urine dip, then you'd want to do complement levels. You'd want to do an ANA, and ANCA levels, and if the patient had elderly, or you suspect immunoglobulin related diseases, then obviously you'd look for myeloma screen, and you do an anti-GBM as well. And ultimately, renal biopsy is a tool that we can do, and gives us the histology of what's actually going on in the kidneys. This is a picture of a H&E stain of a glomeruli, which is it's a normal looking glomeruli, with normal cells and normal thickness of the glomerular basement membrane. It's basically a normal glomeruli. All right. So in terms of management, early detection, as I said, is very important. And in the next slide, we are going to know why it's important. The second thing that we are going to look for is whether there is any indication of renal replacement therapy, whether I'm dealing with any acute complication of acute kidney injury that I need to replace the renal functions in the form of dialysis. So we are going to talk about those indications. And then obviously we need to know the baseline renal functions. We need to know whether our patient is hemodynamically stable, as I said, that going through the ABCDE protocol, looking for airway, breathing, circulation, and that, just to make sure that your patient is stable enough. Volume status, it's I think in terms of management, if you're at night, and you're a foundation doctor or an SHO, or even a resident, and you just stabilize the volume status of the patient, I think you have done your job. I think it's the most important step in management, in terms of dealing with acute kidney injury. And then stop the damn drugs. So D for diuretics, A for EC inhibitor, ACE ARBs, and M for metformin, N for NSAIDs. So any patient, if you detect that he had an AKI, or if you suspect that the patient can develop acute kidney injury, very high risk of acute kidney injury, then it's only prudent to stop these drugs and any nephrotoxic for that matter. All right. So as I said, we need to detect it early. Why we need to detect it early? So the normal diagnostic markers that we use to detect acute kidney injury normally are creatinine and urea. We are at this stage. So the moment creatinine is high, you can see that the damage is already done. I think this is I cannot even cannot stress enough on this point. So the moment creatinine is high, so I usually hear my colleagues saying that, oh, it's the creatinine hasn't risen that much. It's just 1.5 in milligram units. I'm talking about. So a rise of creatinine from 1 to 1.5 may not look um, too much in numbers, but in terms of nephron loss, it's 50% loss of nephrons. So the moment your creatinine jump from 1 to 1.5 or from 100 to 150 in micromoles, you've already lost your 50% of GFR. So if I see a patient with creatinine of 1.5, it means that his GFR is already less than 50. Uh, so this is a point that we need to understand, that a creatinine of 1.5 is not normal. A creatinine of 2 is not normal. It may not look, oh, it's because you cannot wait for it to get to 10, or to that sort of a figure. Then you will start worrying about your patient, because the damage is already done, and then whatever you do would be secondary prevention and just therapeutic. These markers, some of the markers are at developing stage. They are in research. They haven't come through to clinical practice. If they are developed, I think we would be able to detect acute kidney injury at an earlier stage, and we be able to prevent nephron loss. So complications or indications, as we said, that acute complication of acute kidney injury and indications for renal replacement therapy. So the four more important and something which is commonly occurring is hyperkalemia, that is potassium of more than 5.5. So there are an ECG changes related to it, and includes tall T waves, broad QRS, and then at the end, if the potassium is more than 7 or something like that, you develop sinusoidal waves, and that's a bad news for your patient. We all know how to deal with hyperkalemia. Every hospital has their own guidelines, and they can be easily found. We know that if there are ECG changes, we need to stabilize the heart with calcium. You can give calcium gluconate or calcium chloride, whatever there is available. Just make sure that you do give it, and then insulin glucose, and you can use that to get the potassium lower. And obviously we need to call the ITU team or the renal team, just to make sure that we are managing that patient. Metabolic acidosis. So obviously you're going to do a VBG or an arterial blood gas. Look for pH and look for bicarb. If your pH is low, if your bicarb is low, means that you're dealing with a metabolic acidosis. Pulmonary edema, another acute complication of acute kidney injury. And we know that on examination, if you have bilateral crackles, if your patient had edema, shortness of breath, and it doesn't have any, other causes or risk factors for develop a pulmonary edema, I think you can understand. You can do in a chest X-ray or imaging that will clarify, with upper lobe diversion on a chest X-ray, congestion on a chest X-ray, and bilateral infiltrates. Obviously, in the current scenario, you'd be thinking about COVID as well. Uremia. So let me ask you a question. Um, what if I inject, let's say, uh, 20 grams of urea in a patient, what do you think what will happen? 20 gram of urea directly into someone's vein. So normally we think uremia is just high urea. So the answer to the question is nothing will happen. Urea, creatinine in itself, they are not toxic. They are just metabolic end products, and they are just markers that tell us that our kidneys are not filtering it properly. So if you inject 10 grams or 20 grams of urea into somebody, it's not going to affect anything. Uremia is basically a syndrome in which involves metabolic derangements, which the symptoms start from nausea, weight loss, decreased appetite, and leading to the in severe form uremic encephalopathy. So it's a syndrome involving metabolic derangements. It's not just high urea. As I said, we have uremic pericarditis and uremic encephalopathy, which means emergency. So if you're dealing with any of these situations, then obviously you need to call your renal team and your ITU team and make sure that your patient is in safe hands, and it would need a urgent senior review. So we come to our second case. It's a 25-year-old female admitted with fever, malaise, blood pressure of around 80 or 50, heart rate of 130, petechial rash, and lactate of around 6, creatinine of around 120 with baseline renal function creatinine of 50. So 120 here would mean 1.2 in milligrams, and 50 would mean 0.5 milligrams. And this is the petechial rash, the picture. So how will you approach this case, and what do you think is wrong with this patient? So as I said, we go through the same structure. We look for any causes and risk factors. We look for the probable cause, whether we are dealing with pre-renal, post-renal, or renal. Obviously, we look at any emergencies. So this patient is not hemodynamically stable. His blood pressure is around 80 or 50 and heart rate of 130. He had a high lactate and he had an acute kidney injury because the creatinine is more than 25% higher than its baseline. So this patient, and she's a young lady with fever and malaise. So I think we are dealing with an emergency here. And most likely it's an acute kidney injury because the baseline renal function were just 50, which are plumb normal. And so how will we manage? So okay, so red flag sepsis. These are the guidelines from NICE guidelines. They recommend that if we look for these signs in our patient, so whether the patient is unresponsive, acute confusional states, systolic hypertension, tachycardia, tachypnea, a rash, a lactate of more than 2, or any organ dysfunction. So if we go back to our patient had hypertension, tachycardia, patient had a rash, or patient had a lactate of more than 6, and she had an organ dysfunction in the form of acute kidney injury. So I think we have 4 or 5 signs of red flag signs of sepsis here. So we are dealing with sepsis, and by looking at the picture, I can bet my money on meningococcal sepsis. Most likely it's a meningococcemia. So if you detect sepsis and you think that patient had signs, red flag signs of sepsis, then these 6 steps you need to take within the first hour of dealing with the patient. You need to make sure that his oxygen saturation more than 94%. Obviously in COPD, we would be targeting 88 to 92, but in normal individuals, it should be more than 94%. So give oxygen if needed. Take blood cultures, uh, give appropriate antibiotics to cover for both empirical therapy in the form of covering um, uh, gram positives, gram negatives, and as well as anaerobes. Measure the serial lactates. So obviously we'll be doing VBGs or ABGs to measure lactate levels at regular intervals. Make sure the patient is receiving fluids, but make sure that he's not fluid overloaded. So fluid resuscitation should be started, and in urine output. So get a catheter in, measure accurate urine intake and output. I think these 6 steps need to be taken according to the UK Sepsis Trust, to be taken within the first hour of detecting any sepsis. And if you have taken appropriate measures, and let's say you dealt with a patient in the morning, and in the evening you see that your patient is not improving despite all the measures that you have taken, you have to involve your ITU team then. You definitely want your seniors to come and review this patient at an earliest. Okay. So management of because we are, in this case we are dealing with sort of a dealing with sepsis, which is sort of a pre-renal as well as renal injury. So optimization of volume status is very important after giving all the 6 steps that we have taken. I think the important thing would be to optimize the volume status. So for that, first we need to assess fluid status. As I said earlier, it's the most important step. And then obviously in terms of what sort of fluid we should give. So studies have been done, trials have been done, whether we should give colloids or crystalloids. But crystalloids are preferred because they're cheaper, easily available, and you can give any isotonic fluid in the form of isotonic saline or plasmolide. How much to give? So make sure that mean arterial pressure is more than 65, while some authorities do recommend keeping MAP, mean arterial pressure of more than 80. But if you keep it more than 65 of mercury, I think your patient will be in safe hands. Um, and how much to give? So the Surviving Sepsis campaign, it recommends to start with 30 ml per kg of fluid resuscitation. So that means for a 70 kg person, you'd need 2 liters of fluids in the first few hours. In the first hour or so, you'd need 2 liters. So start with that. And then obviously it's an ongoing process. It's a dynamic process to make sure you're assessing the fluid status and everything. So once you have resuscitated the patient, you have started fluids as a medical resident, but the patient is deteriorating. He goes into ITU, and somebody is enthusiastic like me and he's continuing fluids. What do you think what will happen? The patient doesn't have any urine output, and somebody like me is giving him fluids and fluids and fluids, because we think that if we give more fluids, he's going to pop it out of the kidneys. So a fact trial was done on that, um, that after initial resuscitation of the patient, after initially stabilizing the volume status of the patient, and if the patient goes into ITU, further flooding him with fluids, it would actually harm your patient. It would actually delay the exit out of the ITU. It would increase a number of days on ventilators. So after initial resuscitation, make sure that the patient is euvolumic and he's not overloaded. Okay, coming to the third case, it's a 75-year-old male gentleman admitted with confusion, pain abdomen. He has a tender suprapubic swelling. Creatinine baseline is around 70, and creatinine on admission is around 170. That is 1.7 in milligrams. The bladder scan revealed 1,000 ml of urine, and you can see the image of of the bladder, which is showing a distended bladder. If you don't have facility of bladder scan, I think an ultrasound can be easily done. I know it's difficult in UK to get an ultrasound done. It's easier to get a CT done, but ultrasound is difficult to get in UK. But I think in Pakistan, you can easily get an ultrasound. It's available in the emergency hours as well. So you can get a ultrasound that will, ultrasound QUB, that will not only give you a good view of the kidneys, but it will also rule out any post-renal obstruction, post-renal AKI. I think here we are dealing with a post-renal AKI in the form of obstructive nephropathy. So an urgent catheterization measuring urine output, fluid status, and monitoring the renal function. Obviously, we like to involve the urology team to make sure that they manage whatever was causing this obstruction. It could be a prostate in this case, or any other form of she would need urological intervention. So we would go through the same pattern, looking for causes, looking for risk factors, make sure that the patient does not have any emergency complications, and the patient is hemodynamically stable. Obviously, here we are again looking at an acute event because the baseline renal function were normal. And obviously, in terms of management, we know that it's a post-renal AKI. So in terms of management, an important thing would be urgent catheterization. All right, coming to the next case. It's a 44-year-old female admitted with confusion, hemoptysis, dyspnea. Chest has bilateral crackles. Blood pressure around 180 over 110. Hemoglobin of 7, creatinine of 650, with metabolic decompensation in the form of potassium of 6.6 by carb of 10. X-ray image is there. What do you think? COVID, right? So as they say, it walks like a duck. It looks like a duck. It sings like a duck. So it's a duck. Well, sometimes a can be a duck as well, don't you think? All right. So I've personally dealt with two patients, similar patients, during this pandemic. Um, this patient was initially treated as COVID, um, but it wasn't. So if you deal with something like this, I think in the MCQs and MRCP MCQs, you would get another thing that would be to check for KCO. KCO is it's a transfer factor for coefficient for carbon monoxide. Usually it's low in pulmonary edema or any form of pulmonary fibrosis or anything like that. So the KCO will be low, but if it's high, it's very specific and sensitive for alveolar hemorrhages. So this patient had this chest X-ray. It's if you can see, it doesn't have any upper lobe divergence. It's usually in the mid zones. So it looks more like alveolar hemorrhages. So this patient had alveolar hemorrhages, and what we call, as we spoke about it earlier, the pulmonary renal syndrome. So it's one of the pulmonary renal syndrome. This, in terms of kidneys, we call it rapidly progressive glomerulonephritis because the creatinine is jumping too early, too quickly. You do an ANA ANCA levels anti-GBMs. This patient was positive for C-ANCA, and the diagnosis here is granulomatosis with polyangiitis, which we call Wegener's granulomatosis. So obviously, we would like to involve the renal team at an earliest. So they stabilized the patient, did hemodialysis for that patient, did plasma exchange, and a renal biopsy was taken. The biopsy here, you can see the picture. It's showing crescents. It's a crescentic glomerulonephritis, which is a hallmark of rapidly progressive GN. And this is a picture of a blood vessel, which is showing fibrinoid necrosis, which again is a hallmark of Wegener's. This patient would need immune suppressive therapy in the form of pulse solomedrol, which we call methylprednisolone. So he'll need a high dose of methylprednisolone and immune suppressive therapy in the form of cyclophosphamide. And if we intervene earlier, this patient kidneys can be salvaged. All right. So sometimes it can be. So keep an eye open for these pulmonary renal syndromes. They can come and act like COVID, but they won't be. Okay, now briefly touching, I know we are getting short of time, so I'll just run through contrast-induced AKI, which is commonly seen. So first of all, what is a contrast-induced AKI? So it's a diagnosis of exclusion. So if you do not have any other explanation for deranged renal function, and you know that your patient had contrast in the last 48 to 72 hours, that is 2 to 3 days after the contrast, and the patient developed acute kidney injury, then if there is no other cause, then you would know that this is contrast-induced AKI. The treatment is usually supportive, and the patient will kidney function will resolve around in 2 weeks. Important thing is to identify those at risk. So any patient with CKD, any patient who had a heart failure, any patient who is an elderly diabetic, they are at risk of developing contrast-induced AKI. Trials are done as to what we should do about it, how to prevent it. So the KDIGO guidelines, which are guidelines for kidneys, nephrology, they recommend to give either normal saline or bicarb. And preserved trial were done. It was a trial, a randomized controlled trial, which to look for any to look for saline versus bicarb versus N-acetylcysteine, and it showed that there is no statistical difference, significance of any of the treatment. So it doesn't matter if you give bicarb, N-acetylcysteine, or saline. Just give something. Make sure the patient is fluid resuscitated. Make sure the patient is euvolumic. So a normal saline, if it's easily available, would do the job for you. Okay, so coming to COVID-19 and AKI, so it's a study from New York. The statistics are showing that 30% of the patient with COVID develop AKI. That is 1 in every 3. So 1 in every 3rd patient of COVID will develop acute kidney injury. The risk factors are old age. Obviously, it was done in New York. So black race, and hypertension, diabetes. These are all risk factors to develop an AKI. And the mortality is quite high. So if you develop an AKI, with COVID, your mortality jumps to up to 20-25%. If you are in ITU on any respiratory form of support like CPAP or ventilation, and you develop an AKI, the mortality is more than 50%. It's around about 70-75%. So AKI with COVID is a bad news. The mechanism of AKI and COVID-19, so it's multifactorial. So biopsy findings from COVID patients in China, Italy, America, they've done some studies, and they've found the viral particle within the kidney tubules. So we know that ACE2 inhibitors, ACE2 receptors, they are widely distributed in the kidneys, which is the entry point for this COVID virus. And they're widely present in the kidneys. So there's a direct injury to the kidneys. That's one mechanism. And then we know that about the cytokine storm, which can affect the endothelium, and that can lead to acute kidney injury as well. Then we have sepsis, pneumonia, and hypovolemia that can lead to acute kidney injury. And we know that COVID is a hypercoagulable state, and microthrombi and microemboli can lead to acute kidney injury. So it's multifactorial. In terms of management, so we need to educate, assess, and look for AKI in any patient with coming to the COVID. So any patient with COVID, make sure that you have checked his full blood count, creatinine, and UNEs, stop nephrotoxics, make sure that the patient is volume resuscitated, optimal fluid status in every patient, make sure that she is euvolumic. Any rise of creatinine of more than 26 millimoles or 0.26 in milligrams, or more than 50% rise in the baseline, or decreased urine output will quantify that the patient had an acute kidney injury. Treatment is generally supportive. The patient need to be euvolumic. Thromboprophylaxis in the form of giving Clexane or Fragmin. So to make sure that we know that it's a hypercoagulable state, so make sure he's thromboprophylactic given. And dexamethasone in the recovery trial in UK has proven benefits. So make sure your patient is on dexamethasone. Indication for renal replacement therapy would be the conventional indication for renal therapy. So no surprises here. Okay, just briefly touching renal replacement therapy. The big question was an enigma, that when to start renal replacement therapy in acute kidney injury. This START AKI was a trial, multi-center RCT, including 168 hospitals in 15 different countries in patient with ITU. So two groups are there: accelerated strategy, which start dialysis within 12 hours, and the standard strategy, which delay the dialysis unless and until indicated. Uh, the patient, there were adverse effects related, found in patient with accelerated strategy groups. So the morbidity and mortality in accelerated group, those patients who had dialysis at the earliest, less than 12 hours, had actually worst outcomes. So not jumping and jumping in the patient, giving him a, a line, and giving him dialysis will not benefit your patient. So make sure it's tailor made, it's a patient oriented decision, and case to case based decision involving the ITU team as well as the renal team. So the indications for renal replacement therapy, we know that a refractory hyperkalemia, that you have given the treatment, your potassium is not coming down. It would mean that a patient would need renal replacement therapy. Refractory metabolic acidosis, refractory pulmonary edema, persistent AKI3 even after treatment, it's not coming down, the patient is deteriorating. Uremic encephalopathy, uremic pericarditis, these are all indications for renal replacement therapy. And also, if the patient had lithium, aspirin, methanol, or ethyl glycol toxicities, you can do dialysis to get these out of the system. Creatinine is not mentioned anywhere, so no amount of creatinine is an indication for acute for renal replacement therapy. We can start hemodialysis for somebody with creatinine of 3, and we can delay dialysis for somebody with creatinine of 10. So creatinine in itself is not an indication for renal replacement therapy. You have to look at the patient overall, look for these indications, and discuss it with the renal team and the ITU team. Um, do we have time?
Um,
Uh,
I think we have,
5 minutes.
we can take
Okay.
5 more minutes.
Okay. So it's just only 2 or 3 slides left. So the different modalities of renal replacement therapy that are used. So hemodialysis, hemofiltration, and combining these two will make hemodiafiltration. The basic mechanism between these two, dialysis and filtration, is that hemodialysis use diffusion as its basic mechanism. We know that diffusion is movement of particles along the concentration gradient. So it's solute clearance uh, across semipermeable membrane, along with the concentration gradient. So we know that the blood has high amount of urea in a CKD or AKI patient, and the dialysate has no urea. So the urea particle will move out of the blood into the dialysate. It is that simple. While the hemofiltration use convection as the basic mechanism. So pressure is applied, hydrostatic pressure is applied, which gushed out the water through the semipermeable membrane with the process of convection. And as the water moves out, it takes some of the solutes with it as well. So convection is the mechanism for hemofiltration. So diffusion and convection, these are the two basic mechanisms that are that the hemodialysis and the hemofiltration respectively take advantage of. And if you combine both these processes, it would constitute hemodiafiltration. We can get intermittent renal replacement therapies and continuous renal replacement therapies. In a continuous renal replacement therapy, usually it's done in ITUs, whether the patient is attached to the machine for more than 12 hours, usually 18 hours or something like that. The advantage of continuous renal replacement therapy is that we know that with dialysis, hemodynamic instabilities are there, risks are there. So the continuous renal replacement therapy in the form of continuous veno-venous hemodialysis, continuous veno-veno hemodialysis, hemofiltration, the benefit of them is that you can use it in somebody who is hemodynamically unstable, somebody with cardiac issues. So you can use that, and usually use in ITU, because the septic patient, severe sepsis, you have hemodynamic instabilities. So this would help you. Intermittent renal replacement therapies, you can play with it. It's normally done the conventional hemodialysis that we do, 3-hour session, 4-hour session, 5-hour session. These are the intermittent renal replacement therapies. Take home message. So prevention is better than cure, and early detection and intervention will not only save lives, but it will save thousand of bucks for your health system. And as we say in cardiology, that minute is myocardium. That is, every minute counts for every myocardium. I would say the same thing for kidneys. Every minute you lose will lose your nephrons, and they're not coming back. Nephron does not have regeneration capacity. I know the tubular epithelium does, but the nephron, the glomeruli, they don't. So if you lose a glom, you lose it permanently. So make sure you intervene earlier. These are my references. Any questions?
Thank you so much, Zia, for the excellent talk. Indeed, it was very useful. Any questions from the participants?
Can I ask a question, Zia?
Yeah, sure.
Yeah, it's regarding the nephrotoxic induced AKI, or if we are already not nephrotoxic contrast induced AKI, if we're already planning contrast for a patient, is it still educated to withhold any drugs that would cause problem if it gets accumulated, for example, metformin or any nephrotoxic, and if yes, for how long?
I think the good thing is to withhold it. Although one of the study is looking into it whether we should stop the AC inhibitors or not. But I think because AC inhibitors and the NSAIDs, they play with the hemodynamic, the homeostasis mechanisms of the kidneys. So I think stopping it would be good for the kidneys, because the kidneys would be able to, maintain its blood supply, maintain its homeostasis. And I think if you're planning, if the contrast is necessary, so medicine is becoming individualized. You have to deal with it case by case. So if my patient has an acute cardiac event, myocardial infarction, with a creatinine of, let's say, 1.5 or 1.7 or 2, uh, will I stop giving him any PCI? I don't think so, because the patient is dying of cardiac injury anyway. I mean, I can do something about the kidneys, but I can't do anything about the heart. So it's case to case. You have to make sure that you know what your patient wants and what your patient needs. Obviously, discussing it with the patient is useful. Always include your patient in decision making. So if contrast is necessary and there's no other way around it, obviously, then you have to take a calculated risk, make sure your patient is euvolumic, make sure that other nephrotoxics are stopped, and so that, I mean, you can get what you want, and at the same time, your kidneys will be salvaged as well.
Thank you.
Uh, Zia, thank you for this nice talk. I have a question. Uh, when you start consider dialysis in a patient and AKI, do you quote any figures to the patient or the attendants regarding further dependency on hemodialysis? But because this question is asked every time this discussion comes in, the perception is that the perception by the layman is, if a dialysis is once started, the patient will need it lifelong. Do you have such experience of discussing these things beforehand?
I think I think it's a very important question, and it's a question that nephrologists deal with, I think, on daily basis. It's a very common question from the patient, and the common reason of why the patient does not opt for dialysis is that because they think that once started, you will be needing it lifelong. What I used to tell my patient, it's a bit funny, but I used to tell them that I wear glasses, not because the glasses need me, but I need the glasses. Uh, so if you need dialysis, it's just a treatment modality. It's just to, overcome your solute load, your toxic levels, your creatinine is high, your other metabolites, toxic metabolites are there in your blood. If you don't do dialysis, I think there is 100% certainty that you're going to be in a worse condition. So it's just a treatment modality, just as I know it's a bit invasive, it's invasive, and there are risks included with it, but it's just a treatment. Just you would never question, I think, antibiotics in any patient with sepsis, because you know that it's a standard of care. In the same way, if a patient had acute kidney injury, his kidneys are not working, obviously you need a way around it. You need to uh, you know make sure that this patient is clearing his solutes, and if his own kidneys are not doing it, you're taking advantage of the machine. The question that what would be the timeline, I think nobody knows. It depends on what sort of a kidney injury is there. As I said, if it's a tubular injury, there are chances of recovery, even if it's a glomerular injury, like the case that I discussed, that the patient had a Wagner glomerulomatosis with creatinine of 650. Most of these patients do recover. Most of the patients with lupus nephritis do recover despite being on dialysis for a month or 2 months. They do recover. So it's not something that they don't. I think most of the patients do recover with appropriate treatment. But obviously, if there is cortical necrosis and the kidneys, most of the nephrons in the kidneys are lost, the injury is so severe, then obviously there's no coming back from that. So it's I think what I would do is I would sit with my patient, explain what's going on, explain what the patient's problem is. I think the common problem is usually miscommunication. I remember dealing with a lot of patients who would refuse treatment, but when you sit with them, you talk with them, you let them go through whatever you're dealing and doing for them. I think they agree at the end of the day. It's just a matter of communicating with your patient, explaining their worries, telling what's going on. And dialysis is something they can stop at any moment. It's not something that you have to do it. But obviously, if your kidneys need it, if you need it, you have to do it. And if your kidneys recover, you won't need it. But when will they recover? It's a matter of time. I think particularly in ATN, when there is no urine output and the patient is in uric, the frequent question is, when will I get better? And I usually tell my patient that when you start peeing, when you start your urine output, you will know that your kidneys are starting functioning. So it's a difficult question to answer. I know it's hard in terms of on part of the patient, it's hard on part of the doctors as to how to tackle it. But I would say sit with your patients, communicate, explain the risks involved, explain why you're doing it, and what benefit will he get. I think he will agree at the end of the day.
Thank you, Zia.
Yeah.
This is Saidu Group of Teaching Hospital, Swat, Pakistan.
Mm-hmm.
My question is during contrast-induced nephropathy, the iodine-based dye, which is normally used in cardiac interventions,
Mm-hmm.
not frequently, but we do have some cases of contrast-induced nephropathy. So, what do you think the role of this N-acetylcysteine, sodium bicarb? So, what's your opinion regarding these interventions?
As I said, so the PRESERVE trial was done to look into which treatment is better. It included 3 arms. It had N-acetylcysteine, it had bicarb, and it had normal saline, and all 3 was trialed and studied, and the outcome was that there's no statistical difference in using any no one is better than the other. So I think an important thing is that because normal saline is easily available, you can give bicarb just to reduce any of the acidosis and everything like that. But I think if you have normal saline, and make sure that you give at least a liter 6 hours before the intervention, and after, during the intervention, as well as after the intervention. So I think make sure that your patient is receiving fluids. I think your patient will be fine if we just give him normal saline even. But you can use bicarb, you can use N-acetylcysteine, but In terms of science, in terms of which one is better, so the trial has been done, and it doesn't reveal that any of these interventions are better than the other. So all can be used.
Thank you, Zia.
Thank you.
Any other questions from any other participants? All right. If not, then we probably would wind up the session. Thank you so much, everyone, for joining us in. And thank you so much, Zia, for the useful talk.
My pleasure.
And inshallah, we shall see you all for the next session. If anyone needs certificates for these, please drop in your emails. I have noticed all the emails which were shared earlier. And for the Sedu Hospital, thank you so much, Dr. Hadi, again, for joining us in. And if the participants, they need a certificate, please email me the attendance sheet and we'll sort out the certificates.
Okay, inshallah, we will email you the email address.
All right. Thank you so much, everyone.
Thank you. Thank you for your time.
Allah Hafiz.
Thank you. Allah Hafiz.
Allah Hafiz.
Allah Hafiz. Thank you, Zia.
Thank you. Thank you, everyone. Have a good day.